Hello, everyone. I'm Ayodipupo Oguntade. This is part of the hypertension didactic lectures organized by the African Regional Advisory Group of the ISH. So I'll be discussing today hypertension in special populations. So at the end of this lecture, the participants should be able to understand the need for guidance and guidelines for hypertension management in special populations. And when we say special populations, we mean individuals with HIV/AIDS, diabetes, elderly people, children, for those with COVID-19, and to also understand the principles of management of hypertension in these individuals according to current guidelines, and to be able to know and organize the referral of such individuals to hypertension specialists when necessary. So we'll be following the following outline. So as a form of introduction, hypertension is a leading cause of cardiovascular morbidity and mortality worldwide. In fact, in Africa, it's the single most important risk factor for several cardiovascular diseases like stroke, heart failure, ischemic heart disease, and also substantially contributes to the clinical course of other health conditions like diabetes and kidney diseases. Health workers should be aware of current guidance on hypertension care in special and vulnerable populations. So we'll first be discussing hypertension in pregnancy. Hypertensive disorders in pregnancy affect about 5 to 10% of pregnancies, and they are it is the major cause of maternal, fetal, and neonatal morbidity and mortality. And hypertension in pregnancy is defined as a office blood pressure value of systolic blood pressure of 140 mm of mercury or above, and or diabetes or diastolic blood pressure of 90 mm of mercury or more. And it can be mild or severe. Mild meaning a systolic blood pressure between 140 to 159 and diastolic between 90 and 109, or severe hypertension meaning a BP of more than or equal to 160 over 110. So it's been classified in several ways. The ISH Global Hypertension Practice Guidelines as classified hypertension as shown on this slide. And we have what we call pre-existing hypertension, meaning hypertension that precedes the index pregnancy, or when hypertension develops in pregnancy before 20 weeks of gestation. And gestational hypertension is hypertension that develops after 20 weeks of gestation, and it usually resolves within 6 weeks of delivery. Now, these are individuals with hypertension in pregnancy after 20 weeks of gestation without proteinuria. Now, there's an entity called pre-existing hypertension with superimposed gestational hypertension with proteinuria. Now, these are individuals who may have had hypertension prior to the index pregnancy, and then developed proteinuria during the index pregnancy. Proteinuria meaning they had protein, significant protein or albumin in their urine during antenatal visits. Now, we have another entity called pre-eclampsia or eclampsia. Pre-eclampsia is gestational hypertension with significant proteinuria, meaning an albumin creatinine ratio in the sports urine of more than or equal to 30 milligrams per millimole, or protein in the urine of more than 300 milligrams in 24-hour urine. Now, when somebody has hypertension after 20 weeks of gestation with proteinuria and suffers a seizure or a fit, it is called eclampsia. Now, there's an entity called HELLP syndrome. This occurs in pre-eclampsia or eclampsia, and the acronym is for hypertension, elevated liver enzymes, and low platelets. Now, this is an abnormal liver and clotting disorder that occurs in those who have severe pre-eclampsia in pregnancy. And there's an entity called antenatally unclassified hypertension. Now, sometimes patients are noted to have high blood pressure after 20 weeks of pregnancy, but it is unclear whether the hypertension was pre-existing before the pregnancy or not. In such a case, the physician can diagnose the condition as antenatally unclassifiable hypertension. Many of these individuals will subsequently be found to have either pre-eclampsia or gestational hypertension. And sometimes it can be a diagnosis made in retrospect, meaning after 6 weeks of delivery, if hypertension does not resolve, then if it resolves, then those individuals will be said to have either gestational hypertension or pre-eclampsia. But if the hypertension does not resolve after delivery, so after 6 weeks postpartum, then maybe they had an antenatally unclassified hypertension at the time, and then they need to be followed up. And some of these individuals may then be diagnosed later on with hypertension, straightforward hypertension or persistent hypertension. The risk factors for hypertension in pregnancy include general risk factors in the population, high salt intake, obesity, family history of hypertension, and also some specific risk factors which are specific to pregnancy. For example, those in their first pregnancy have a higher risk of having hypertension in pregnancy. Those who have multiple pregnancy, meaning those with either twins or triplets in this pregnancy, or those with what we call molar pregnancy, those with either 34 mole, which is a type of abnormal pregnancy, which is a trophoblastic disease. Those with pre-existing hypertension, even prior to the index pregnancy, have a risk of sustaining the hypertension in pregnancy or developing other entities in pregnancy like pre-eclampsia, eclampsia. Individuals with diabetes, renal disease, autoimmune disorders like antiphospholipid syndrome, systemic lupus erythematosus, kidney disease, hypertension in previous pregnancy. So all these are risk factors. Now, what happens in pre-eclampsia? It's been said that excess placenta secretion of some factors like soluble tyrosine kinase receptor like SFLT1 and SAENG, which inhibits vascular endothelial growth factor and transforming growth factor beta, which are growth factor that stimulates blood vessel formation and placenta growth. So when these soluble mediators or soluble receptors are secreted in a large amount, they tend to inhibit the signaling of growth factors that are necessary for proper vasculation of the placenta. And this results in endothelial cell dysfunction with impairment in nitric oxide production and release of coagulant proteins around the placenta attachment region, which causes rise in blood pressure. Now, blood pressure measurement in pregnancy should be done using manual auscultation in the upper arm, as studies have shown that automated devices may be unreliable in pregnancy. Now, there's a caveat here. If the automated device has been shown to be validated in pregnancy, it can be used in the clinic. Now, sometimes one may need to do 24-hour ambulatory blood pressure monitoring or do home blood pressure monitoring using validated devices, especially when trying to find out whether the hypertension is just white coat hypertension, meaning that some of these individuals have high office blood pressure readings in the clinic, but at home their blood pressure is normal. So that's what is called white coat hypertension. So in order to tease this out, one may need to do 24-hour ambulatory blood pressure monitoring or home blood pressure monitoring. So how do we investigate pregnant women with hypertension? Now, all pregnant women should be screened for hypertension and preeclampsia at their first antenatal visits and at each visit during the pregnancy period. And they should have routine blood tests like full blood count, liver function tests, because as we said earlier, there's an entity called HELLP syndrome in which there is abnormal liver function test and low platelets. So we need to do full blood count, liver function test. We need to check that their serum electrolytes, urea and creatinine because of kidney dysfunction, which may be a cause of hypertension or may result from hypertension in pregnancy. Some studies have shown that measuring the serum soluble FLT1 to placenta growth factor receptor to placenta growth factor ratio can be used to diagnose preeclampsia occurring in the week after it is suspected. So if the SFLT1 to placenta growth factor ratio is less than or equal to 38, this effectively excludes preeclampsia in the following week. Now, women with hypertension in pregnancy need to have a kidney ultrasound done to rule out pre-existing renal or coexisting renal disease. They also need to have Doppler scan of the uterine arteries done because this can show abnormalities that are peculiar to pre-eclampsia, and it can also be shown. It can also be used to investigate intrauterine growth restriction or growth retardation. Spot sample urine should be taken in all pregnant women at each visit and at the first prenatal visit to screen for proteinuria or albuminuria, which is one of the diagnostic criteria for preeclampsia. And a dipstick of 1+ or more of urine of protein in the urine should prompt evaluation for albumin creatinine ratio in a spot urine sample. And like we've said earlier, an albumin creatinine ratio of less than 30 milligrams per millimole effectively rules out proteinuria in pregnancy. And in such cases, patient can manage as hypertension in pregnancy alone without preeclampsia. Now, the goal of treatment for hypertension in pregnancy is to reduce maternal risk while balancing fetus risk, because some of these medications for hypertension may have unknown effect on the fetus, and not treating hypertension in pregnancy also puts the fetus at risk, and a high blood pressure can cause fetal distress. And so general measures include bed rest, regular diet. Please don't do salt restriction in women with hypertension in pregnancy, because a large blood volume is required is required during pregnancy. One tend to initiate current guidance advised to initiate blood pressure treatment, hypertension treatment in those with a blood pressure of more than 150 millimeter mercury systolic and or 95 millimeter of mercury diastolic. However, if patients are symptomatic, then blood pressure hypertension should be treated once BP is more than 140/90 in pregnancy. Now, what are the first-line therapy drug options? Traditionally, methydopa, we call it Aldomet in Nigeria. Beta blockers like labetalol have been found to be safe, and especially labetalol has both oral and intravenous formulations. The intravenous formulation can be used in severe preeclampsia to bring down the blood pressure and also in hypertensive emergencies. Diadopa calcium channel blockers like nifedipine, amlodipine have been shown to be safe in pregnancy. And those with pre-existing hypertension can continue their previous drug regimen. However, we should not use angiotensin converting enzyme inhibitors like lisinopril, ramipril, or angiotensin receptor blockers like losartan, valsartan, candesartan. We should not use these drugs, or direct inhibitors like aliscreen. We should not use them in pregnancy because they cause serious adverse fetal and neonatal outcomes. We should also avoid using diuretics like hydrochlorothiazide or any of the thiazide-like diuretics like indapamide during pregnancy, because it causes contraction of blood volume, and this can worsen preeclampsia. We need to avoid. There's a idolizing is a good. It used to be very commonly used for bringing down blood pressure, but in pregnancy, but it can cause catastrophic blood pressure drop, so it is better avoided. Now, when using IV labetalol in severe preeclampsia to bring down blood pressure, or when using it in hypertensive urgencies or emergencies in pregnancy, patients should not exceed a cumulative dose of 800 milligrams in 24 hours. Now, despite the fact that methydopa or Aldomet is good and safe in pregnancy, it should not be used postpartum in those who continue to have high blood pressure post-delivery, because it increases the risk of postpartum depression. Also, we need to be aware that many antihypertensives are secreted into breast milk, even though in minute amounts, except for nifedipine and propranolol, which are secreted into breast milk in similar concentration to their plasma concentration. So we may want to avoid nifedipine and propranolol after delivery and probably switch patients to other antihypertensives that are not secreted in large amounts into the breast milk. So this is an algorithm from the 2018 European guidelines for management of arterial hypertension in pregnancy. Now, in women with gestational hypertension or pre-existing hypertension superimposed, or those with pre-existing hypertension superimposed by gestational hypertension, or those with subclinical organ damage or symptoms, it is advised to initiate hypertension treatment even if the blood pressure is just more than or equal to 140/90 of mercury. However, in all other cases, hypertension treatment can be delayed until a BP of 150 of mercury systolic or diastolic of more than or equal to 95 of mercury. And like I said, with methydopa, labetalol, calcium channel blockers like nifedipine, amlodipine are safe and are the drug of choice in pregnancy. We should avoid ACE inhibitors or ARBs or direct inhibitors, as I've said earlier. Systolic blood pressure of more than or or equal to 170 millimeters of mercury, or diastolic of more than equal to 110 millimeters of mercury, is an emergency in pregnancy, and admission to hospital is recommended. So if you see any patients with this kind of blood pressure, please refer to an appropriate specialist setting. Now, in severe hypertension, we tend to use IV labetalol, oral methadone, or nifedipine. The recommended treatment for hypertensive crisis, meaning those with hypertensive emergencies like heart failure with high blood pressure during pregnancy, or those with other hypertensive crises like encephalopathy, we tend to prefer, so IV labetalol or IV nicardipine is preferred, and IV magnesium sulfate is very good for treatment of pre-eclampsia or eclampsia. In those with pulmonary edema, nitroglycerin can be given as IV infusion. However, never use IV sodium nitroprusside because it has been associated with fetal cyanide poisoning. In women with gestational hypertension or mild preeclampsia, delivery should be expedited at 37 weeks. And it is recommended to expedite delivery, especially when patients have visual disturbances or hemostatic disorders like HELLP syndrome. Please, in this setting, urgent delivery is recommended. So how do we prevent hypertension in pregnancy? It is now this depends on the risk of the person developing hypertension in pregnancy. Now, individuals can have high risk of developing hypertension in pregnancy, like those with hypertensive disease during a previous pregnancy, those with chronic kidney disease, those with autoimmune disease like systemic lupus erythematosus or antiphospholipid syndrome, those with type 1 or type 2 diabetes, those with background chronic hypertension. These are all individuals with high risk of developing hypertension in pregnancy. Whereas those with moderate risk include those in their first pregnancy, those who are age 40 years and above, those whose last pregnancy was more than 10 years before, and those with a high BMI of more than equal to 35 kilograms per meter square, meaning those who are obese at their first visit, those with family history of preeclampsia, and those with multiple pregnancy. So these are individuals with moderate risk. In these individuals, 100 to 150 milligrams of soluble aspirin used daily from 12 weeks of pregnancy up to 36 weeks of delivery is advised. So we move on to another special population, which are children. Now, hypertension in children is defined as a systolic blood pressure and or diastolic blood pressure that is persistently at or above 95 percentile for age, sex, and height. And the diagnosis is based on demonstration of elevated or hypertensive level blood pressure at 3 separate encounters, unless the patient is symptomatic. Now, in children with predisposing conditions associated with hypertension like obesity, diabetes, kidney disease, heart disease, such children should have routine blood pressure checks at every contact with health services to detect hypertension. And manual auscultation is preferred in making the diagnosis and following up these children. In specific cases, we can use ambulatory blood pressure monitoring to confirm hypertension diagnosis and to rule out white coat hypertension, to evaluate blood pressure pattern in those with kidney disease, those with sleep apnea, those who are transplant recipients, and to monitor the treatment efficacy in individuals in children who are already on treatment for hypertension. We can use ambulatory blood pressure monitor or home blood pressure monitor. And individuals, and it can also be used to diagnose masked hypertension. So sometimes some of these children with predisposing conditions may actually have hypertension, which is not picked up in the hospital. So, but when you do ambulatory blood pressure monitoring, or when you do home blood pressure monitoring, one can pick up these high blood pressure readings, and that's what is called masked hypertension. Now, it is important to mention how that there are pediatric sized sphygmanometers that can be used to check blood pressure in children, and it's important to always check whether the bladder cuff size is at least 40%, covers at least 40% of the upper arm circumference, and the device, the cuff should also at least cover 80% or more of the length of the upper arm, so that one can get accurate readings. So this is an algorithm from the ESC guidelines for hypertension diagnosis in children. So as we'll see here, in those who are less than 16 years of age, if the blood pressure is less than 98th percentile consistently, then that is normal tension, and there's no need to further check the blood pressure except if the individual is at high risk for developing hypertension, like for example those children with diabetes, previous those with kidney recipients or heart recipients, those who have had transplants for either kidney disease or heart disease or any other diseases, and or children who have who are obese. In such cases, we need to be checking the blood pressure consistently at every contact with health services. However, if the blood pressure is persistently less than 98th percentile in children with no comorbid illnesses, then they have normal tension. Or if the child is already 16 years and above, if the blood pressure is less than 130 by 85 to mercury, then this is normal tension. Now, in children who have persistent BP, who have a blood pressure reading more than 98th percentile for age, and they are less than 16 years, or those with a blood pressure of more than equal to 130 by 85 to mercury, and they are 16 years of age or more, then we need to check the blood pressure readings at subsequent visits. And once we have 3 readings, which are abnormal, meaning either between 90 to 95 percentile or more than 95 percentile, then we need to monitor these children. In those who have blood pressure reading of 90 to 95%, above 90 to 95 percentile for age, sex, and height, or a BP of 130 to 130 millimeter of mercury systolic, or 85 to 90 millimeter mercury diastolic, then this is high normal. We need to continue checking blood pressure because they may soon reach the threshold for hypertension treatment. Now, if the blood pressure is more than 95 percentile for age, sex, or height, or more than 140 or equal to 140 90 of mercury, then that's hypertension. We need to evaluate the child for the etiology of the hypertension. Is it due to diabetes? Is it due to kidney disease? Is it due to vasculitis or glomerulonephritis and some other conditions that's treated with high blood pressure in children? And also to investigate for organ damage. So in such cases, we need to check the serum electrolyte, urea creatinine, check the kidney via ultrasound, check the fasting blood glucose to rule out diabetes, screen the family for inherited conditions, and so how do we manage hypertension in such children? Now, indications for treatments are 3. So children with persistent hypertension readings, despite lifestyle modification, especially when they have an abnormal echocardiography, where either they have a left ventricular hypertrophy on echocardiogram, poor ejection fraction on echocardiogram, or they've got valvular malformations, or if they are symptomatic of the hypertension, whether they have blurred vision, headaches, and any other hypertension symptoms, or children with stage 2 hypertension without a modifiable risk factor, or any stage 2 hypertension in children with diabetes or CKD. All these require treatment. Even though there are very few long-term data on safety of antihypertensive medications in children, generally angiotensin-converting enzyme inhibitors like ramipril and lisinopril, or angiotensin receptor blockers like losartan, valsartan, or long-acting calcium channel blockers like amlodipine, or thiazide like hydrochlorothiazide or clothalidone are the recommended initial agents for pediatric patients with primary hypertension. Now, in those with chronic kidney disease or diabetes, or those children with proteinuria, angiotensin-converting enzyme inhibitors or angiotensin receptor blockers are preferred, and they are the initial agents for use. And the goal is to reduce the blood pressure to less than 98th percentile for age, or less than 130 over 80 of mercury, whichever is lower, based on office or casual blood pressure readings. And for those with chronic kidney disease or those with diabetes, blood pressure should be monitored by ambulatory blood pressure monitoring, and recommended goal blood pressure, especially in those with CKD, is a 24-hour mean arterial pressure less than 50th percentile. This is based on evidence from the ESCAPE trial. So this is an algorithm from the 2016 European Society of Hypertension guidelines, and as we see here, it says that the blood pressure goal in children with hypertension is blood pressure of less than 95 percentile. However, we should strongly consider treating to less than 98th percentile in such children, because this treating to a lower threshold improves cardiovascular risk, improves their risk of suffering adverse cardiovascular outcome. Now, in children with diabetes, the blood pressure goal is lower. So it's a mandatory blood pressure goal of less than 90th percentile for age, sex, and height. Whereas if the child does not have proteinuria, then the goal can even be lower up to 75th percentile. However, if the child has proteinuria in addition to CKD, then in addition to CKD, then the goal blood pressure is to treat to less than 50th percentile for age, sex, and height. Now, for those children with CKD ab initio, so a lower threshold, even lower than the threshold for diabetes, is mandatory. So we treat to a goal of less than 75th percentile for age, sex, and height if the child does not have proteinuria. If the child has proteinuria, then we treat to less than 50th percentile for age, sex, and height. So, and lower here, we'll see what the equivalent threshold is for those children who are already nearing adult age, those who are age 16 years and above. So, like I said, so this is an algorithm from the European guidelines showing the different drugs that can be used. Generally, drugs on the green continuous line are preferred. So we can use combination of thiazide with angiotensin converting inhibitors. We can add calcitonin antagonists to it, like amlodipine and nifedipine, and we can use angiotensin converting enzyme inhibitor with calcitonin antagonist. So note that we don't tend to use ACE inhibitors together with AR because they target the same pathway. So we can also use thiazide with ACE inhibitors. We can use thiazide with calcitonin blockers. We can use thiazide with angiotensin converting enzyme with angiotensin receptor blocker. Sometimes one may want to use thiazide with beta blockers, even though we need to be cautious. However, those on the black dashed line, it's possible to use them, but they are not well tested. For example, one may want to use beta blocker with ACE inhibitors or beta blocker with calcitonin blocker, but these are not tested combination regimes. It's important to say that this particular combination is not recommended. So don't use ACE inhibitors with ARBs because they target the same pathway. Now we move to another special population, which are elderly. So prevalence of hypertension in elderly, those who are age 65 years and above, is about 70 to 75% in population surveys, meaning 3/4 of elderly people will have hypertension in their lifetime. And this is because arterial stiffness tends to increase. The vessels become hardened, and aortic compliance reduces with age. And when the aorta becomes stiff, it leads to reduced compliance and a rise in reflected blood pressure in central blood pressure reading, and this leads to wide pulse pressure. Pulse pressure is the difference between diastolic and systolic blood pressure. So, and if the pulse pressure is more than 60 meters of mercury, that's a wide pulse pressure. So in elderly people, you tend to have wide pulse pressure and increase in total peripheral resistance, which leads to a rise in systolic blood pressure. Note that many a times, the diastolic blood pressure does not rise. So, and they tend to have what we call isolated systolic hypertension. Treatment is tricky because most elderly people are also on several other medications for different comorbidities. Many of them have diabetes, some are on treatment for dementia, some are on treatment for anxiety, and some other health challenges. Some of them may be on treatment for kidney disease. They may be on treatment for coronary heart disease, and for example, they may have angina and all sorts of conditions. So, and when you add antihypertensive to their drug regimen, it becomes difficult to manage, and because these are elderly people, some of them with cognitive decline, they can easily become delirious and become confused when you treat with so many medicines, and many of these medicines also affect, also tend to reduce blood pressure. So, and that can cause orthostatic hypotension in elderly people, especially when hypertension control is too tight. So as I've said here, polypharmacy and tight blood pressure control increases the risk of falls, confusion, delirium, and orthostatic hypotension. Orthostatic hypotension is an abnormal drop or exaggerated drop in blood pressure on assuming the upright posture. Generally, when we stand up, blood pressure tends to drop slightly. But if you have a systolic blood pressure drop of more than 20 minutes of mercury from supine to rising to the upright position within 3 minutes, or after 3 minutes, or the systolic blood pressure drop of more than 10 minutes of mercury within, after assuming the upright posture within 3 minutes, or after 3 minutes, then that is orthostatic hypotension. Now there is an entity called pseudohypertension. So this occurs when there is a major discrepancy between intra-arterial invasive blood pressure reading and cuff blood pressure using this sphygmomanometer in the office. So sometimes some patients will have high blood pressure when you check their blood pressure with the BP monitor, but when you do intra-arterial blood pressure recording using intra-arterial probes, blood pressure is normal. Central blood pressure is normal. So in that case, we call it pseudohypertension. Now, blood pressure variability is also very common in elderly. So you check their blood pressure sometimes in the morning, blood pressure is slightly lower. In the afternoon, it can rise. It can be very variable. So generally, it is advised that blood pressure should be measured in the standing position, and the standing blood pressure should be used to guide treatments so that we don't over-treat patients. So imagine if you check the blood pressure while sitting or supine, and you say blood pressure is high, and you start treatment. So, and if those patients have postural hypotension, you wouldn't know, and they are predisposed to fall. So, but if you check the blood pressure while standing and use that to guide treatment, that is better. So there's an entity called masked hypertension in elderly people. So meaning that you check the blood pressure in the clinic, it's normal. When they get home and they use their blood pressure blood pressure monitor, or you put in an ambulatory blood pressure monitor for them, they have high blood pressure readings at home. So that's masked hypertension. Also, elderly people tend to have absence of nocturnal dip in blood pressure readings. Normally, blood pressure drops in the night. But in those with hypertension and even elderly, they may not have nocturnal dip in blood pressure readings. So always watch out for the diastolic blood pressure when you treat elderly patients, especially those of them with wide pulse pressure, meaning the difference between systolic and diastolic blood pressure. If it's more than 60 units of mercury, then you need to really be careful in treatment. Don't over-treat them. Don't lower diastolic blood pressure below 65 to 70 units of mercury in such individuals, because low diastolic blood pressure has been associated with increased adverse events. So it's important to do geriatric assessment of all elderly patients before they are started on antihypertensives. And in fit elderly patients, especially those who are less than 80 years, the goal blood pressure is systolic blood pressure goal of less than 140 units of mercury. That should be the goal. Whereas in those of them who are fit but older than 80 years, the goal blood pressure should be slightly higher. So aim for a blood pressure below 150 units of mercury. Even though the Americans recommend target of 130 by 80 units of mercury, will advise to use a higher target of 150 units of mercury. So, whereas if the patient is 80 years and above and they are very frail or have several comorbidities, it is better to withhold or reduce antihypertensive doses once systolic blood pressure is less than 130 units of mercury, or when they start developing orthostatic symptoms, orthostatic hypotension. So, in those with orthostatic hypotension, we use a higher systolic blood pressure goal of 145 to 160 units of mercury. This is safe. So don't say, I must treat to 140, I must treat to 120 units of mercury. Don't do that. Lifestyle changes is important, and we can use calcium channel blockers like amlodipine. It's a very gentle drug that can be used in elderly people. Thiazide can be used, but be careful of those individuals of those elderly who also have diabetes, because some elderly people are prone to dehydration. They may not be drinking enough, so be careful. ACE inhibitors like lisinopril, ramipril can also be used if tolerated, but we tend to avoid beta blockers like atenolol, bisoprolol, and all the other beta blockers, because they have been associated with increased risk of confusion, and confusion is one of the risk factors for falls. And it's also associated with bradycardia and heart block and hypoglycemia in elderly people. So it's better to avoid beta blockers. However, if a patient has compelling indication for beta blocker like atrial fibrillation, please prescribe, or refer to an hypertension specialist or cardiologist. So this additional algorithm by Bennetos et al. So it's divided in the elderly people into 3 different categories: those with preserved function, and those with loss of function but they have preserved activity of daily living, and those with loss of function and altered activity of daily living. Now, in those who have preserved function, so therapeutic approach is similar to young adults. A BP systolic blood pressure goal of 120 to 140 of mercury is advised. He has advised that, but like I said earlier, elderly people, please just use a target, a threshold of 140 if they are preserved function. But if they are frail, use a threshold of 160 or 150 of mercury. Start with monotherapy and titrate the antihypertensive medication cautiously. Always check for orthostatic hypotension, and optimize treatment for global cardiovascular disease prevention, meaning treat dyslipidemia with statins, treat high blood glucose. Now, in those who have loss of function, but they still have preserved activity of daily living, meaning that they still retain their independence, they can still ambulate. But they have loss of function, meaning that they are frail, but they still have some autonomy. So they need detailed frailty assessments in order to tailor the antihypertensive treatment and balance the risk of CVD prevention against the benefits of treatment, against the risk and benefits of treatment. So, and once you do a frailty assessment, refer to a geriatrician to do this. If you don't have, so there are elderly people's clinic, in some hospitals, refer them there. We've got one at University College Hospital in Ibadan, in Nigeria. Here we have geriatricians that see patients that see very old, that see elderly people with hypertension. So do geriatric assessments, and if you think that if they think that the benefits of treatment outweighs risk, they can prescribe them antihypertensive, but always check for orthostatic hypotension and use a higher BP threshold of maybe 150 or 160 of mercury. Now, if the patient is very frail and they are no longer independent, they are bedbound or they are very frail, they cannot go about their usual activities, then one may need to reconcile and revise antihypertensive therapy. If the blood pressure is very high and you must treat, please start with one drug at a very low dose. Probably start with calcium channel blocker like amlodipine, 2.5 milligrams daily, and then titrate upwards and go slow. Like I said, systolic blood pressure goal of 150 of mercury is advised. Avoid using more than 3 antihypertensive medications. In fact, usually you will not need to use more than 1 or 2 medications in very frail individuals. If BP is less, systolic blood pressure is less than 130 of mercury, or patient has orthostatic hypotension under treatment, please reduce antihypertensive medications and consider using monotherapy, or consider stopping medications, all antihypertensive. Consider stopping all antihypertensives. Identify and correct other factors that may be dropping the blood pressure. For example, some of them may have autonomic neuropathy. Some of them may be on medications, antidepressants that can also reduce blood pressure, or anti-diabetic agents that have an effect on blood pressure readings. So you need to consider all this. So in all these cases, always refer elderly, especially those who are frail, refer them to hypertension specialists and geriatricians. Now we go to another special population, those with diabetes. So prevalence of hypertension among those with diabetes is about 47 to 60% in population surveys. Both hypertension and diabetes act synergistically with each other to cause target organ damage, heart failure, left ventricular hypertrophy, kidney disease, retinopathies, and several other target organ involvement, and they increase the risk of macro and microvascular complications in diabetes. In the hypertension in diabetes increases the risk of macro and microvascular complications. Macrovascular complications include heart attacks, peripheral vascular disease, heart failure. And microvascular complications will include things like peripheral neuropathy, retinopathies. So the pathogens of hypertension in diabetes include sympathetic overactivity, activation of urinary angiotensin-aldosterone axis, abnormal sodium handling, endothelial dysfunction, reduced insulin-mediated vasodilatation, inflammation. So there's a large study called the UKPDS study. This study showed that reducing blood pressure from 162 over 94 mmHg to 144 over 82 mmHg reduced diabetes-related mortality, heart failure mortality, and other macrovascular complications. And benefit of blood pressure control in diabetes has been shown in other studies, HELLP study, ASCOT study, HOT study, and SHELP trials. So the threshold for treatment in diabetes is 140 mmHg systolic or 90 mmHg diastolic. And like I said, blood pressure control prevents and reduces the risk of microalbuminuria or proteinuria. It reduces onset of new or worsening nephropathy. It reduces the risk of diabetic kidney disease and also reduces cardiovascular risk. Masked hypertension and resistant hypertension are common in diabetes. So ambulatory blood pressure monitoring and home blood pressure monitoring is very crucial. All diabetic patients should have their own blood pressure monitor, and they should keep a chart of their blood pressure at home. This can be used to guide treatment when they come to the hospital, when they come to the clinic. In those with proteinuria or diabetic patients with chronic kidney disease, or those who are deemed to have high cardiovascular risk, for example, those who have had a stroke before, or those who have had amputation, or those who have suffered macrovascular or microvascular complications, we tend to advise tighter control, a blood pressure target of less than 130 by 80 mmHg. And some have even said less than 125 by 75 mmHg is preferable. And the first drug of choice in diabetic patients, especially those of them with albuminuria, with albumin creatinine ratio of more than equal to 300 milligrams per gram creatinine, is to use an ACE inhibitor or ARB. So you can use lisinopril, ramipril, or you can use losartan, candesartan, valsartan, irbesartan. So the ARBs like valsartan, they are more expensive than ACE inhibitors, but they don't have many of the side effects of ACE inhibitors like cough, angioedema. We can also we can add calcium channel blockers, diiodopyridine calcium channel blockers like amlodipine, nifedipine. We can add it to their medications to achieve good BP control. We can use diuretics. We can use even though thiazides may cause some degree of glucose intolerance, but low dose diuretics, hydrochlorothiazide of 10.5 milligrams per day, does not really have much metabolic effect. Some anti-diabetic medicine also have hypotensive effects, like SGLT2 inhibitors, like dapagliflozin, or GLP-1 receptor agonists, like liraglutide, or DPP-4 inhibitors. So these medications have in the BP lowering effect. They can achieve about 8 to 4 mmHg reduction in systolic blood pressure, but they should not be used as standalone therapy for treating hypertension in diabetes. So it's just that diabetic patients who are at high cardiovascular risk should be prescribed these medications in addition to their blood pressure medicines. This will guarantee better blood pressure control and better glucose control. Always monitor diabetic patients for orthostatic hypotension because of autonomic neuropathy, autonomic dysfunction that is common in diabetes. And also monitor patients especially patients who are on several antihypertensive, monitor them for metabolic effects of these drugs. So this is a chart from Sheikh et al. 2017. Thiazides have been shown to cause glucose intolerance. They can raise the blood glucose, and they can also cause dyslipidemia. They can raise low density lipoprotein cholesterol and cause a low HDL. So always monitor fasting blood glucose and fasting lipids in patients who are on this medicine. Beta blockers like bisoprolol, atenolol, they can also theoretically raise blood pressure, and they can also raise serum triglycerides. So but be aware of hypoglycemic unawareness that is common in patients, in diabetes patients who are on beta blockers. So you may want to use, you may not want to use beta blockers in those who are at risk of hypoglycemia. Calcium channel blockers, they are neutral. They have neutral effect on glucose and lipids. They are very good and fantastic drug. And they are also very safe, but sometimes they can cause a rise in proteinuria or increase in proteinuria, so always watch out. So doing checking the urine maybe every 3 months or every 6 months may be considered. ACE inhibitors like ramipril, lisinopril, they are neutral on glucose and neutral on lipids, and they are very fantastic for the kidneys. They prevent proteinuria and reduce proteinuria, and they reduce the risk of diabetic kidney disease. So they are preferred as first line therapy, like I said earlier. Alpha blockers, especially in those with resistant hypertension, meaning those who are on more than 3 different antihypertensives, including a diuretic, and you can't achieve blood pressure control. You can have the alpha blocker. They don't have any effect on glucose in diabetic patients. They even raise HDL and lower LDL, so they are good for the serum lipids, especially in those with dyslipidemia. So alpha blockers can be used in those patients. Now we move to a vulnerable population, patient living with HIV/AIDS. So hypertension prevalence among people living with HIV/AIDS is higher than in general population, and it's been said that about 35% of those on highly active antiretroviral therapies have hypertension. Traditional risk factors appear to not explain the excess burden of hypertension among these individuals, and the possible mechanism for hypertension in HIV/AIDS has been touted to include chronic inflammation, immune reconstitution, meaning as when patients are started on HARTs and their CD4 counts improves and viral load reduces, blood pressure tends to rise. And this is because poor HIV control causes a sepsis-like state with increased vascular permeability. And when patients are started on HARTs and their immune status is reconstituted, blood pressure tends to rise. Lipodystrophy, especially those on protease inhibitors, they have abnormal lipid deposition and altered lipid and dyslipidemia. So all this can affect downstream renin-angiotensin aldosterone system pathway. There is no definite association between hypertension and HIV infection duration or HIV severity, so we should always keep this in mind. But patients with HIV/AIDS who have hypertension have higher risk of cardiovascular events. So they are more likely to suffer strokes, more likely to suffer heart attacks, heart failure. In fact, there's an entity called HIV-associated cardiomyopathy. So how do we manage hypertension in individuals living with HIV/AIDS? So we should always screen for hypertension at HIV diagnosis before starting antiretroviral therapy and annually while patients are on antiretroviral therapy. Management is similar to general population, but we should watch out for important drug interactions, which I will show in the next slide. Medication adherence is very critical, and this is a big challenge for people living with HIV/AIDS. So it's difficult for them for some of them to adhere to several medicines, especially if you are treating with 2 or 3 different hypertensives in addition to their heart, which may also be 3 or 4 different medicines. So consider fixed drug combinations to improve adherence. Nowadays, many patients with HIV are on fixed drug combinations for treatment of the HIV/AIDS. And if you prescribe fixed drug combination for the hypertension, that may also improve adherence. So meaning that they won't have to use more than two medicines in a day. So you can consider either mono or combination therapy. But when you are using several medicines for BP control, introduce a drug at a time and titrate to the maximal dose before adding the other. And you can either use thiazides, or you can use calcium channel blockers, or ARBs or ACE inhibitors. So if there is poor response to 2 different antihypertensives, please refer to a hypertension specialist. Don't continue to treat. Refer to the hospital. Refer to hypertension clinics. Lifestyle medication and hypertension medication is very important, and designing simple treatment algorithms can allow integration of hypertension clinics into HIV care in low resource settings. So who should you refer to the experts for BP control? any patients with HIV/AIDS who has a blood pressure of 180 or over 110 Newton mercury or more, or those who with uncontrolled blood pressure following initiation and titration of 2 antihypertensives to maximal tolerated doses, or those. So you should refer immediately individuals with blood pressure of more than equal to 180 or 120 Newton mercury, especially when they have target organ damage, meaning those with encephalopathy, those with stroke, those with pulmonary edema, those with renal disease or hypertensive nephropathy, or so please refer this set of individuals urgently to specialist centers. So this slide is showing drug interactions in HIV, antihypertensive interactions in HIV/AIDS. It's important to note that antihypertensives do not affect HIV medicines. So they do not reduce the dose of HIV medicines. They do not affect the drug concentration of HIV medicines. So there is no concern about what, if you are using antihypertensive, you have that they may have effect on drug levels of antiretrovirals. No, they don't have effect on drug levels of antiretrovirals. However, some antiretrovirals have effect on drug levels of antihypertensives, and you may have to adjust upwards or downwards the dose of the antihypertensives to achieve blood pressure treatment effect that you want. So, for example, individuals who are on efavirenz or nevirapine. So these two medicines they lower the serum or blood levels of amlodipine. Whereas those on protease inhibitors like lopinavir, atezanavir, or dapirnavir, they tend to this antiretroviral medicine tend to increase the serum level of amlodipine, meaning that when patients are on these protease inhibitors, drug levels of amlodipine tend to rise, and you tend to have better blood pressure control and a potent hypotensive effect. Whereas when patients are on efavirenz and nevirapine, you may have to increase the dose of amlodipine to achieve the same effect. Now, enalapril, which is an ACE inhibitor, does not have any. So HIV medicine do not have any effect on drug levels of enalapril. However, efavirenz and nevirapine reduces the drug level, the serum level of bisoprolol. So when patients are on bisoprolol, you may want to increase the dose to achieve the same effect that you would ordinarily achieve if they were not on efavirenz or nevirapine. Now, these arrows in red, these red boxes show a very severe effect that protease inhibitors have on bisoprolol. So they tend to increase the serum level of bisoprolol. So, and individuals who are on protease inhibitors are prone to side effects of beta blockers like heart block if they are on beta blockers. So you may want to reduce or review the doses of bisoprolol in patients who are on this drug and they are also on protease inhibitors. So you need to always keep an eye on such patients. So, and when you use this kind of drug, because beta blockers and protease inhibitors increase the risk of QT prolongation, so which is a cause of sudden cardiac death or ventricular fibrillation. So it's important to do ECG monitoring when you are placing patients on this medicine. Now, to the last in the group of special populations, COVID-19. Hypertension in COVID-19 has been a controversial topic since the beginning of the COVID pandemic. Hypertension is an independent predictor of adverse outcome among those infected with COVID-19. And we all know these days that the virus binds to the angiotensin converting enzyme 2 receptor on cells. And this particular receptor is similar to the angiotensin converting enzyme receptor that ARBs also block. So there has been concern about whether ACE inhibitors and ARB could potentially cause poor outcome in COVID-19 because it was said that when you use ACE inhibitors or ARBs in such individuals, you tend to have high circulating amount of the virus, and that can cause adverse outcome in individuals. But
Also, some have said that polymorphism in ACE2 receptor gene in ethnic minorities may explain the excess COVID mortality in Africans and other ethnicities. Well, it's important to note that till date, there are no randomized control trials that have demonstrated the benefits or risk of ACE inhibitors or ARBs, either on the incidence or outcome of COVID-19. Observational studies have not shown any harmful effect of these medicines in individuals with COVID-19. And the risk of poor blood pressure control when these very wonderful antihypertensives are stopped appear to substantially outweigh any theoretical adverse effects they may have in individuals with COVID. Most hypertension societies, including the ISH, International Society for Hypertension, Europe, the ESC, the American Heart Association, all of them advise against stopping antihypertensive in COVID-19. So, including not stopping ACE inhibitors and ARBs. There are no credible data to back some of the published opinions that said we can stop ACE inhibitors and ARBs in individuals with well-controlled hypertension during the pandemic, during the COVID-19 infection. There is no data to back up this opinion. So if patients are on ACE inhibitor and ARBs and they are doing fine on it and blood pressure control is fine, please continue COVID-19. So this is the verbatim statement from the ISH. The ISH, so which was published at the peak of the pandemic. The ISH completely endorses the contents of two recent statements made by the Council on Hypertension of the European Society of Cardiology and the European Society of Hypertension, both of which made clear that there is no good evidence to change the use of ACE inhibitors or ARBs for the management of raised blood pressure in the context of avoiding or treating COVID-19 infection. So we can, this is a link, we can Google the document. So ACE inhibitors refer to include lisinopril, ramipril, and enalapril, and ARBs include losartan, candesartan, valsartan. So in conclusion, so hypertension in special populations require individualized approach and attention to details by health workers. Always refer your patients in this category to a hypertension specialist as early as possible, because this will allow optimum care and reduce risk of long-term complications. Thank you very much for listening.